Today we'll discuss about Caesarean section. What are the types of Caesarean section? There is classical Caesarean section. We use Sanger's incision. We have lower segment Caesarean section. We use Kerr's incision. And we have chronic incision or Teele incision. It is given in the lower segment but vertically. LSCS is most commonly done. It is a low transverse curvilinear incision. As I said, it is also called as Kerr's incision. So the lower segment stretches during labor and it is a non-contractile part relatively. What are the advantages? Bleeding is less, repair is easy, healing is better, and chances of rupture in next pregnancy is very less. That is 0.2 to 0.9 percentage. In case of classical cesarean section, the incision is in upper uterine segment. The upper uterine segment is relatively thick and it is a contractile part. The disadvantage of using a classical cesarean section is bleeding is more, repair is difficult, healing is not that good, and the risk of rupture in subsequent pregnancy is very high. That is 4 to 9 percentage. So you have to remember that after LSCS, due to indications other than contracted pelvis, we can try vaginal birth after C-section or trial of scar. If history of previous two LSCS is present, you can try for vaginal delivery. If there is history of previous three LSCS, you should do cesarean section. After classical cesarean section, due to any reason, even one, you have to do cesarean section. What are the indications for classical cesarean section? When access to the lower segment is difficult, that is, lower uterine segment is harder into bladder, severely contracted pelvis, or in case of carcinoma cervix, when there is morbidly adherent placenta is attached to the lower segment. In case of placenta previa, the lower segment is not formed. That is, in case of early preterm pregnancies, the lower uterine segment will not be formed. In such cases, you have to do a classical cesarean section. Sometimes in a back down transverse life fetus, it is better to assess the fetus in case of a classical cesarean section than a lower segment cesarean section. In chronic incision, what are the indications? In case of constriction ring present, chances of rupture is high and viva can't be tried. Can cause bladder injury if it extends. The anesthesia used in C-section is preferred. We prefer spinal anesthesia at the T4 level. So, what are the indications for general anesthesia? It is severe fetal distress in certain heart disease condition. That is the pneumonic SHEP. In case of intracardiac shunt HOCM, decreased ejection fraction conditions like severe AS or AR, pulmonary hypertension, in severe eclampsia, umbilical artery Doppler showing absent end diastolic flow, you have to do C-section at 34 weeks. In case of reversed end diastolic flow, you have to do earlier, that is 32 weeks. WHO, you have Robson's classification or 10-point classification. It is used to compare the rates and indications of C-section. Five parameters are used, that is parity, which whether primary or multi-parity, with or without previous history of C-section, gestational age, whether term or preterm, and presentation, whether cephalic breech or transverse lie, and the number of fetuses, whether single or multifetal pregnancy, whether the pregnancy is spontaneous or induced labor. So in case of primary term cephalic presentation with single fetus, if it is spontaneous, spontaneous or induced, if it is spontaneous, it comes under group 1. If it is induced, it comes under group 2. In case of multiparity, without previous history of C-section and term and cephalic and single fetus, if again it is spontaneous, it comes under group 3. If the labor is induced, it comes under group 4. In case of group 5, we include multi-gravid with previous history of C-section. In group 6, we include primary with breech. In group 7, we include multiparity with breech. In case of group 8 and 9, you can remember the mnemonic MTP, multifetal pregnancy, transversal and preterm fetus. Before C-section, you have to ask for consent and Foley's catheterization should be done. Antibiotic prophylaxis should be done. In case of elective, 60 minutes before C-section, and in case of emergency C-section, you have to give as soon as possible. The drug of choice is cephalosporin. Most commonly used is cefazolin IV, 2 grams single dose or beta-lactam antibiotic. In allergic patients uh, who are allergic to cephalosporin or beta-lactam antibiotics, you can use clindamycin plus gentamicin combination single dose. If blood loss is greater than 1.5 liters or the duration of surgery is greater than 3 hours, antibiotic is needed in the post-op period also. In case of part preparation, shaving is not recommended nowadays. The position of a patient should be supine with 15-degree left lateral tilt of the table, or you have to place a wedge under the right hip to avoid IVC compression or supine hypotension syndrome. Coming to the skin incision, you have midline skin incision or lower transverse abdominal skin incision that is called as phalansteal incision. Phalansteal incision is preferred. The site is 2 centimeters above pubic symphysis. The landmark is just above the pubic hairline. After skin incision, you will be approaching external oblique, internal oblique, and transverse abdominis muscles. Then comes fascia transversalis. Now, the all three muscles aponeurosis merge to form the rectus sheath. Then comes the rectus muscle. Then you will see the posterior rectus sheath and arcuate line. So the rectus sheath, as I said, is formed by the aponeurosis of external oblique, internal oblique, and transverse abdominis. Each aponeurosis has two lamellae, that is anterior lamellae and posterior lamellae. Rectus sheath has superior and inferior epigastric arteries in it. So arcuate line is an important landmark. It is situated between umbilicus and pubic symphysis. That is the midpoint. Above arcuate line, if you see, you have external obliques, anterior and posterior lamellae, and internal obliques, anterior lamellae above the rectus muscle. And below it, you have internal obliques, posterior lamellae, and transversus abdominis, anterior lamellae, and transversus abdominis, posterior lamellae. All this will be forming the posterior rectus sheath. Below the arcuate line, the muscles, uh, internal oblique, external oblique, and transversus abdominis lie above the rectus muscle, whereas the posterior rectus sheath is formed only by the fascia transversalis and peritoneum. The direction of nerve in anterior abdominal wall is traversing transversely. Coming to the iliohypogastric and ilioinguinal nerve, which is the most common nerve injured in C-section. These are sensory nerve. Both of them perforate the rectus sheath just lateral to the rectus muscle. They supply the anterior abdominal wall and skin. Iliohypogastric nerve supplies the skin over the suprapubic area, while ilioinguinal nerve will be coming close to the rectus sheath and it traverses inguinal canal and the superficial inguinal ring, and it supplies the skin over mons pubis, upper labia majora, and upper medial thigh. If inferior epigastric artery is injured and not repaired, it can lead to hematoma formation. So, rectus muscle is not cut. Incision should be given lower down. In case of midline skin incision, there is an advantage of quick entry, more exposure, less bleeding, minimal nerve damage. But wound dehiscence is more as the blood supply is less, so it is cosmetically not good. In case of lower transverse skin incision, it is cosmetically better, stronger, and preferred. So we'll be doing C-section. First, we have to cut the skin, then the subcutaneous tissue, and then you have to reach the rectus sheath. You can make an incision with scalpel and extend with the fingers. You have to separate the sheath from underlying muscle by using back end of the scalpel. Now you can see the rectus muscle. You should not cut the rectus muscle. You should be cutting only the midline aponeurosis. So the muscle will be automatically separated. The posterior rectus sheath, as I mentioned, below the arcuate line is made up of transversalis fascia and parietal peritoneum. You can easily separate fascia transversalis with fingers. The parietal peritoneum should not be cut at this level and it should be cut at a higher level. You have to lift it up and cut with scissors. Now you have to identify the lower uterine segment and you'll be having a loose fold of perineum. You have to pick up with forceps and give incision with scalpel and extend it transversely on both sides. Note you have to keep the tip of the scissor upward to avoid injury to the uterine vessels. You have to push the bladder down by Doyne's retractor and you have to give a incision on uterus, that is a transverse curvilinear incision in the lower uterine segment given by scalpel. Take the fingers beneath the myometrium and extend the incision on both sides using fingers and scissors. Now you have to remove the Doyne's retractor and deliver the baby. You have to deliver the head first, maintain the flexion of head, apply the fundal pressure and look for cord around neck. You have to deliver the anterior shoulder next, followed by posterior shoulder, and the rest of the baby is pulled out. Active management of third stage of labor is same as in normal vaginal delivery. You will be doing delayed cord clamping, controlled cord traction, and then you will be giving oxytocin. After delivering the baby, you have to close the abdomen, make sure hemostasis is achieved, do proper suction of the cavity, and examine tubes and ovary once. Peritoneum can be closed and it can be left open. If it is not closed, it can save time. If it is closed, the advantage is adhesions are less. In case of rectus sheath closure, it's done in a continuous manner. Rectus muscle and subcutaneous tissue are not closed. Skin closure, we close it by simple interrupted subcutaneous suture or by using staplers. Then you can apply occlusive dressing. Last step is vaginal toileting. In case of elective CS you are doing for non-medical reason, you can do it at 39 weeks. Ideal gap between C-section and next pregnancy is 18 months. Minimum gap between C-section and next pregnancy is 6 months. What is type 1 Caesarean section? That is the time decided to perform the emergency Caesarean section and the delivery of fetus should be less than 30 minutes. Previous Caesarean section pregnancy is a high risk pregnancy. It can lead to abortion, ectopic due to adhesion, and preterm delivery, morbidly adherent placenta, uterine rupture, and high risk of PBH. In which cases you can do vaginal birth after C-section or trial of scar. Maximum 2 LSCS in the past. If it crosses or equals to 3, you should do Caesarean section. If the pelvis is adequate, do VBAC. If it is contracted pelvis, then VBAC is contraindicated. The present pregnancy should not be containing diabetes or macrosomia or postpartum pregnancy. If these are present, then it is a contraindication. No malpresentation should be present in the present pregnancy. If malpresentation are present, then it is a contraindication. Indication of past cesarean section should be a non-recurrent cause. You should be doing cesarean section in case of contracted pelvis. It is a recurrent cause. In case of higher center where the blood transfusion facilities are available, you can do VBAC. In case of lower center, we will be doing C-section. No other uterine scar of complete thickness or no history of extension of scar into the upper segment. You can do VBAC. In case of hysterotomy or myomectomy scar, you will be doing C-section. No history of uterine rupture, you can do VBAC. In case of classical C-section, chronic incision or T-shaped incision or history of uterine rupture, we should be doing C-section. What is the chances of success of VBAC? That is 74%, and it increases with previous history of vaginal birth. What is the most important factor for success of VBAC? You have to monitor partograph and CTG continuously. You can induce labor preferably by mechanical methods by using Foley's catheter. Prostaglandin use are contraindicated. You should cut short the second stage by instrumental delivery, and you should monitor for scar integrity every 30 minutes. What are the signs and symptoms of impending scar rupture? In case of scar dehiscence, the serosal layer is intact, but in case of scar rupture, the serosa is also ruptured. The signs and symptoms in maternal is tachycardia, hematuria, vaginal bleeding, and per abdominal examination you have suprapubic tenderness and uterine contractions present. There is no shock or free fluid in peritoneum. In case of fetus, you have fetal heart rates are abnormal. It is a most consistent finding. The first finding is fetal tachycardia. What's the management? You have to stop VBAC and immediately do a C-section. Trial of scar and trial of labor are two different terms. Trial of labor is you will be trying it for CPD without previous history of C-section. What are the signs and symptoms of rupture uterus? In case of maternal, you will be having shock and free fluid present in the peritoneum. In per-abdominal examination, you will be having no uterine contractions felt because the uterus is ruptured, and you will be feeling fetal parts superficially. In case of pervaginal examination, you will be having profuse vaginal bleeding, you have profuse hematuria and loss of station of fetal head. You will be managing as the patient is in shock, you have to resuscitate and exploratory laparotomy should be done. Then you have to remove the placenta and the baby. Then you have to repair the uterus. If the repair of uterus is not possible, you should do a hysterectomy. Thank you.